Hello, I'm Dr. Pamela Morris. I have the pleasure of co-chairing this year's Cardiometabolic Health Congress Women's Health Masterclass. And I'm here today with Dr. Erica Spatz, who is Associate Professor of Medicine at Yale School of Medicine. She gave a great talk this afternoon on depression and poor mental health and cardiovascular risk. And I just wanted to start in our chat here today a little bit about discussing the difference or the overlap between stress, depression, poor mental health. What are the definitions, overlaps, etc.?
Thanks for asking about that overlap. So depression is a clinical diagnosis, and there are specific criteria that we use to diagnose depression. It's also the case that many people have depressive symptoms, so they may not meet a clinical diagnosis of depression, but they do suffer from different elements of depression. And these are colloquial terms, but the difference can be important because the prognosis can be different, depending on whether or not a person has depressive symptoms or a clinical diagnosis of depression, where the latter is more highly associated with cardiovascular outcomes. We find also that depressive symptoms as well as depression co-occur with stressful life events, psychosocial stressors. And these can include a stressful life event. They could also include stress in people's home with their relationships, stress at work, financial stress, stress experienced with discrimination. And these are also independently associated with cardiovascular outcomes. So when we think about psychological factors, we want to think about depression, we want to think about psychosocial stressors, and what I also didn't talk about today are other aspects like anxiety, anger, post-traumatic stress disorder. These are all negative psychological attributes that contribute to cardiovascular risk factors and cardiovascular disease.
So let's talk, are there any gender or sex-related differences in the diagnosis of depression or poor mental health in the, we'll talk in a moment about the cardiovascular risk, but are there gender differences in the prevalence and diagnosis?
So Pam, we find that women have about twice the prevalence of depression than men. It's pretty remarkable. And if we look at cohorts of people with cardiovascular disease, we see those differences play out as well. We did a study called the Virgo study, which was of patients who were under the age of 55 who had acute myocardial infarction. And on presentation, half of women had a prior diagnosis of depression, as compared with a quarter of men. So the rates are very high. In addition, we find that depression portends a worse prognosis for women as compared with men. So what does that mean? That means that women with depression are at higher risk for adverse cardiovascular events than men with depression.
Well, that's really almost frightening from that point of view. Now, one thing I wanted to ask you a little bit, you and I are both cardiologists. Many of those who will be watching this will be in other disciplines in medicine. But, I think about for my annual health visit to my primary care provider, every year we have to fill out a depression questionnaire. The discussion goes no further. I see it show up in my screening assessment, but I never, fortunately, it doesn't come up as a clinically significant. But I think about, as cardiologists, we are now tackling obesity, smoking cessation, difficulty controlling blood pressure, evolving new lipid-lowering therapies, the new diabetes/cardiovascular risk medications. How do we approach the diagnosis, screening, and subsequent management of depression?
There's been such an underdiagnosis of depression that our health system has figured out that we need to standardize depression assessments. And because the visit is so packed with all the things that you mentioned, those questionnaires often are taking place either before the visit or the medical assistant is going through the questions. And it's very hard to integrate into the context of our clinical care. And so many people find that they've answered the questions, but then their surveys are not even addressed during the context of their encounter with their clinician. For all the things that you mentioned, whether it's obesity, whether it's controlling high blood pressure, controlling lipids, or even if it's angina, I think that we need to get into the habit of saying, what's going on in your world? I like to start with the psychosocial stressors because stress is something that everyone can identify with, but we need to make sure that we don't trivialize it and say, oh, it's just part of everyone's life. Everybody has stress. No, we're talking about significant stress. And when we tap into the different domains that this can occur, whether it's at work, at home, related to finances, it gives us a window into people's lives that I think that we need to bring forward so that people can see how their healthcare choices may be impacted by what's happening in the context of their lives. Once we understand that, we can push further and say, well, what about depressive symptoms? Do you have depressed mood, low energy, poor sleep? Are you getting pleasure from activities? And when the answer to those things are in the direction of having more depressive symptoms, then we need to really up the scale of what we're doing and say, I think that depression is contributing not just to potentially your health behaviors, but also to your prognosis. So taking a very focused approach, putting that on the problem list and having some action-oriented plan for patients who have depressive symptoms, who have depression, is really important.
I think a lot of us are afraid when we screen for depressive symptoms, it opens a door, it opens the pathway to a discussion that may not be in our area of expertise necessarily to manage, and therefore too often, at least in cardiology practice, we keep that door closed. The other question I had for you is whose role is it to subsequently manage that, or how do you handle when you identify depressive symptoms in your practice? How do you approach referral, or who should be managing it?
That's right. I think we lack knowledge and we lack resources and tools within our cardiology practices to address depression. And that is a limitation. And that's not to say all practices, but many practices don't have a behavioral health component, don't have a social worker who we can, just excuse ourselves from the room and bring in another person. And we know that our referrals often lead nowhere because there's a paucity of mental health providers in our communities, so wait times are long, so we're often left diagnosing something and yet feeling like we don't have the tools to handle this. What I have been struck by time and time again is that we need to involve primary care. The primary care provider still needs to be at the center of the person's care. And so sometimes it's just reaching out to them and saying, I'm concerned about Jane, and I'm hoping that she can schedule a visit with you to talk about this, because they also have their list of things that they need to cover as well. But really making it a priority. And I think that message is heard really loud and clear when it's clinician to clinician. Sometimes the patient can't advocate for themselves in that same kind of way. So I think our role, even if it's just connecting them back to their primary care provider, is really important.
I think your talk today certainly opened my eyes to the importance of depression and poor mental health. And certainly the data that you presented on its association with cardiovascular risk was really concerning. And I couldn't agree with you more. I do think probably what I think I hear you saying is that we definitely need to open the door, and then we need to direct them to the right or the left and make that connection with their primary care provider. And especially for those of our listeners or participants who are actually in advanced practice professionals, endocrinologists, nephrologists, anyone partaking, caring for patients with cardiometabolic health issues, really needs to open the door and then direct them and help guide them to the care to reduce subsequent cardiovascular risk and improve management. So, well, thank you so much. It was really a wonderful talk today. Thank you all for joining us.